Well, hello, and welcome to another Facebook Live broadcast with MedStar Health. My name is Michelle Carter, and I'm joined today by Dr. Christina Ensman, a gynecologist and menopause specialist with MedStar Good Samaritan Hospital in Baltimore. We're proud to have this discussion in partnership with Red Hot Mamas, the leading nonprofit provider of menopause support and education programs in the US and Canada. Today, things are going to be hot. We're going to unravel the mystery of menopause, hormonal imbalances and other symptoms, the body changes, treatment options, and how to handle those dreadful night sweats and hot flashes. So if you or someone you love is struggling with menopause and needs support or treatment, or if you're managing your menopause and would like to share your experience with us, stick around. Share this broadcast with your friends. Give us a like to let us know that you're watching, and share your questions and comments with us below. We're going to take some time to answer those as well. All right, so Dr. Ensman, welcome, and thank you so much for taking the time to join us today. I'm excited to learn about this topic of menopause and have this conversation with you. So before we get started with some of our questions, could you tell our viewers a little bit about yourself?
Yes, thank you, Meshan, for the introduction. So I'm originally from Germany. I'm just giving you this already because you will hear it. And I went to medical school in Germany, and then for family reasons, I ended up in the US in 2003 and redid my my OBGYN, my training at Baltimore. And then early on, I went as faculty to University of Maryland. And at that time, I realized in practice that I was not well prepared for all the menopausal questions and patients I had. So very early on, I was like, oh, this is a link. I would like to provide answers to my patients beyond just the very brief introduction I got in my training. And I found the North American Menopause Society, and really was immediately was so happy to have found that great source of information, and became a menopausal certified practitioner. So that was one passion. On the other hand, I'm also a minimally invasive gynecologist. And another thing that comes from my time in gynecopathology, I have a doctoral thesis in dermatology, actually, is my passion for vulvovaginal disease. So that's also something I do a lot in my practice. So all skin conditions of the vulva and the vaginal microbiome. And then in the later years now, I have added one more passion, and then I'm done. It's the functional medicine piece. And that's really something I found that there are many questions my patients were asking me where conventional medicine just doesn't have a good answer. Like someone is fatigued, they're tired, and we do blood work, and the doctor's going to tell them, and I would tell them everything is fine. And that was it. And functional medicine now adds that piece of information where we actually look at the root cause of issues and not just try to throw medications or tablets as band-aids on it. And since I do that, really my practice has not been the same. I love it. So that has really expanded all of that. And since 2019 now, I'm actually with MedStar, and I'm currently seeing patients at the Good Samaritan Hospital.
Well, thank you so much for that introduction. And thank you so much again for taking the time to join us. I really look forward to getting some answers to some of our questions. So let's dive in. So we hear often these terms of perimenopause, menopause, and then post-menopause. So could you share, what are the differences between these three conditions?
Yes, so these terms are indeed used in a very confusing pattern by clinicians as laypersons. So I want to start first with that term menopause. And just so you know, what I'm telling you now is a nomenclature that has been made up by a team of very smart researchers. That was called the Workshop of Reproductive Aging, or Stages of Reproductive Aging, and was then abbreviated STRAW. These people met the first time in 2001, and then again 10 years later. So these criteria are now called STRAW plus 10. And this was a really important milestone, because as researchers and clinicians, we were trying to communicate the same things about our patients, or we were trying to do studies. But since these terms are all used in such a confusing way, we never knew if we're actually talking about the same women. So menopause, really for the strict nomenclature, I always like to say, this is not a time span. Menopause, per definition, is your last menstrual period. So, for example, you can be like, well, when was your menopause? And I would say, for example, well, April the 18th, 2018, that was my menopause. Everything that comes afterwards, it's actually postmenopause. And just in case the question comes, we always stay in it. It's never over. You're going to be a postmenopausal woman. There's nothing bad about it, but that's how it is. And then the perimenopause, as the term suggests, it's the time around that last menstrual period, that menopause. And it's by that criteria, it can be from 8 to 10 years prior to the last menstrual period. And it includes the first year after that last menstrual period. That's the perimenopause, which is, by the way, often the time where women are the most symptomatic.
Right, that's good to know about those phases and what to look out for and what to expect down the line. I'm not in that range just yet, but it's good to know what to expect. So thank you for sharing that. So what are the symptoms of menopause, and do they vary from person to person?
Yes, they do. That's I want to say yes, they do tremendously. That really depends on your lifestyle, on your genes, on your epigenetics. So how does your lifestyle affect your genes? But the most, to understand the broadness of symptoms that can occur, I think you have to understand that most of our organs and body systems have estrogen receptors. So I think that's important to know, to understand that so many things can be affected in more or less subtle ways once the estrogen levels start to fluctuate. And I think the most important organ that has estrogen receptors in my mind is the brain. Okay, so most common symptoms we hear about are, of course, the dreaded hot flashes or vasomotor symptoms. I would say that's indeed the thing I hear the most. And they can, however, I want to say most women that I see in my practice just for checkups, and they are in perimenopause or menopause, they actually don't complain that they are terrible. I think that's an important message. There's no pathology behind having a hot flash. It's a symptom of hormonal changes. And if someone just has a little hot flash, but they clothe in layers or use a fan and they're not bothered by it, no problem. The other symptoms I hear the most about is insomnia. So sleeping issues, falling asleep, staying asleep, waking up early. And with that often comes then the brain fog. So suddenly women feel they are not really able to do the executive functions well, the thinking, they can't focus at all. They feel sometimes it affects their work performance. And the other thing is tremendous moodiness. This can go from a light, being more emotional, to feeling cranky all the time, that your spouse notices it, your relationship at works are affected. There's even a term that is called menopausal rage. Sometimes women can become so angry. So these are the ones when people are coming and saying, I need something. Other more subtle symptoms are joint aches and pains. There might be drying of all mucosal surfaces. So there might be drier eyes, drier mouth, and then of course, drier vagina. Sometimes an early sign might be more urinary tract infections and the lower sex drive. That is what also many women do complain about.
Thank you very much. So how do you know if any of those symptoms that you just shared are actually menopause or signs of a different condition altogether? Is that even possible?
That's a very good question. So in general, by criteria, I would say if these symptoms occur after age 45, I would be rather confident that this is most likely what it is. And symptoms we say now, particularly the hot flashes and the moodiness, and particularly also if it comes along with variability in your menstrual cycle length. So meaning from the first time you bleed to the next first time you bleed. When there is it continues more than 7-day variability, you are in early menopausal transition, which can take from 8 to 10 years. So no panic. I'm just saying that could be it. Strictly speaking, for women up after age 40, if menopause occurs, it's still considered normal. However, we also think that's kind of on the earlier side. So for women between 40 and 45, if suddenly they skip their menstrual cycles, become moody and have hot flashes, I would evaluate certainly other possible reasons. One thing that always comes in mind is like thyroid issues or issues with diabetes and blood sugar control.
All right, and what are the signs when menopause ends and when perimenopause ends and menopause begins? And around what age usually can people expect for this to occur?
So the typical age for menopause to occur for this last menstrual period for US women is age 51, 52. And what the question, what is the signs? Okay, well, as I described before, once you have this final menstrual period, and you will only know a year later, right? Because you have a period and you don't know if it comes again. So then once 12 months have passed and you have not had a menstrual cycle again, then you're officially in postmenopause.
All right. So I think you may have shared a little bit about the body changes that people typically go through. But can you, further, explain what typical changes women should expect, like weight gain? I know you mentioned like the brain fog. What other physical changes can we expect to go through?
Yeah. So the bodily changes, again, they are affected by the decreasing estrogen levels. At this point, I want to explain that it's not a gradual decrease in perimenopause. It's mostly, actually, I want to call it like a chaotic up and down roller coaster of the hormones in perimenopause. And then in the postmenopause, these estrogen levels slowly decrease until they have reached a low level. So now with the estrogen again affects so many other body systems, very important for how we perceive our, body changes is the effect on collagen and hydration of skin and connective tissue. So with decreasing estrogen, most women, they do actually note at that time a thinning of their skin, there is more wrinkling, and again, there might be drier mouth and eyes and vaginal tissues. And then, okay, I'm just looking at my little note here, but I'm not missing anything. So weight gain. Let me talk about, well, weight gain is one of everyone, many women come and complain about this, this little belly, the increasing belly they get during that perimenopausal transition, even when they're overall rather on the slender side. So first of all, here I want to say that there are studies that actually do show this weight gain is very modest. It's not tremendous. It's about 1.5 pounds per year. And that's actually only until these hormone levels stabilizes, which is the first 2 years after menopause. So, which, it's an average like 3 pounds. Of course, that's an average of all women, right? And some women might have barely anything and other women have more. But what is for sure known is that we get less lean body mass and more fat mass. So that ratio does turn around. So we lose muscle and connective tissue and we get more fat tissue. And that does accumulate around the abdominal area. Why is now that? So here I'm now reaching out a little bit into functional medicine. So the question always is, what can we do about this and why does that occur? And here I really tell my patient it has to do for most of us with insulin resistance. And that insulin resistance, the end spectrum of the insulin resistant, once it gets really bad, is prediabetes or diabetes. Most viewers might know this term, and that's a conventional medicine terminology. We don't acknowledge really in conventional medicine the the changes insulin resistance can cause prior to an official diagnosis of diabetes. And as we age, and due to our genetics and lifestyle, I want to say most of us have some degree of insulin resistance. What is that? It's basically, you have to understand, whenever we eat sugar or simple carbohydrates, our body needs insulin to put that extra sugar in our cells to help the cells make energy so we feel better. However, the cells only like that insulin and if it comes in a pulsatile fashion every now and then. If we eat all the time or eat all the time the wrong food, the insulin hangs around all the time and the cells will close their door. It says, no more, I have enough of this. And now suddenly all this extra energy and sugar cannot be transported into the cells and help us feel better. But the body is smart and doesn't waste anything. So that extra energy is always then, every time you eat, directly deposited as fat. And that's the typical insulin resistant weight gain is this abdominal fat as well as the intra-abdominal fat, which is covering our organs, and it's highly inflammatory and also not good. So what can we do about it? So really, in a nutshell, I do tell my patients to really minimize, so really let go of sugar. There's nothing else to say. Let go of the sugar, of the candies. You really shouldn't be having that. And then stay away from the simple carbohydrates, but really meaning bread, pasta, even the healthy grains, like the, often it's said, like if you have the whole grain bread or pasta, that is better. It's still causing you an increased blood sugar once you are reaching that perimenopausal age. So my recommendation is let all this go. Whenever you have a plate in front of you and you eat, and it doesn't matter if it's breakfast, lunch, or dinner, it should be 80% plant-based. Lots of greens and veggies, at least 3 to 5 pounds a day, and that's a lot. I hear a lot of patients say, yeah, I eat my greens. I'm not talking about that. I'm talking about 8 to 12 servings. So whatever you eat should be greens, veggies, nuts, and seed, and high quality protein, which can be meat, animal-based, or it can be also plant-based, like legumes, tofu, etc. And then it's often really surprising how with a little change in diet and how profound effects that actually can have on weight loss, however, also on hot flashes. And actually there has been a very interesting study that was showing exactly that.
All right. Yeah, this is all fascinating. Good advice. I think, body can benefit from eating mostly plant-based, low sugar or no sugar at all. So, especially during that perimenopausal phase,
yes,
in order to keep those other symptoms at bay. That's some good advice. So thank you very much, Dr. Ensman. And at this time, I'd like to welcome our viewers again. If you're just joining us now, thanks for tuning in to our Facebook Live. Today, things are getting hot. We're talking about menopause, the changes that people's bodies can go through, treatment options, and how to handle those dreadful hot flashes and night sweats. And we even talk about weight gain. I'm here with Dr. Christina Ensman, a gynecologist and menopause specialist with MedStar Good Samaritan Hospital in Baltimore. We have much more to talk about, so share this broadcast with your friends. Keep watching, give us a like to let us know that you're watching. And of course, if you have any questions for Dr. Ensman along the way, we'll take some time to answer those as well. So that takes me to a few audience questions at this time. So the first one I have is from Melba. Thank you for tuning in, Melba. She asks, when you've had a partial hysterectomy, could that lead to perimenopause? Like, could that, enter you into that phase?
Very good question. So usually we would always say no, because with a partial hysterectomy, that means your ovaries actually stay behind. We don't take them out. We only take the uterus, which is that organ that carries babies and bleeds tremendously or grows fibrous. And the ovaries have their own blood supplies, so they shouldn't be affected by that. However, it kind of sometimes depends, how does the accessory blood supply to your ovaries work? Usually the most blood supplies is independent and comes from the pelvic side wall and not from the uterus. But again, depending how your blood supply is, it might be that your biggest blood supply came indeed from the uterus that is now gone. So then the ovaries don't die off, but they take a little hit, and that can cause an earlier onset of menopause. However, what I do see most of the time is that women do get a hysterectomy when they're already in that time of perimenopause. So then it's often a confounding factor. They might have been close to perimenopause anyway.
All right. Thank you, Dr. Ensman, and thank you, Melba, for sharing your question. We have another one from Stephanie. I think we were going to talk about this in a little bit as well, but I'd like to address it now. So we talked about the symptoms and changes that women can go through during menopause. And she'd like to know, will any of these symptoms go away at some point?
Good question. All right. So yes. So, and it depends, however, what symptoms you're talking about, right? But let's say we stick with the hot flashes and the insomnia. So we have good studies that show most of these symptoms last about 7 years, right? The most symptomatic time is the couple of years before your last menstrual period, and then the couple of years afterwards. So for most women, after 7 years, these symptoms go away, the vasomotor symptoms and the insomnia, and that goes along with what we know about stabilizing low estrogen levels, right? Once all this suddenly calms down and finds the new, that goes away. However, there are about 20% of women who will continue for a very long time, if not forever, with hot flashes. That does not mean that these are all terrible hot flashes, right? So don't panic. But it's just that they still say at age 70 or 80 said, yes, I still get occasionally a hot flash. And I now actually extend this question. There are some symptoms that we haven't really discussed yet. They are part of the late postmenopause. So after 5 to 8 years after the last menstrual period, that is the late postmenopausal time. And at that time, you will have more and more effects on your tissues from the very low estrogen levels. And this is now mostly affecting the vagina. So at that time, there's a term we call genitourinary syndrome of menopause. That just means the low estrogen levels do more and more affect the vaginal tissue and the bladder. So these symptoms usually tend to get worse as you get older, or start as you get longer and longer into menopause. Not everyone gets these. That's, for me, often surprising. And I think that depends how the individual woman metabolizes estrogen. However, the vaginal tissue will become drier potentially or tighter. And the bladder issues are often the lacking estrogen causes urinary frequency and sometimes also some leakage. So that will get worse, and there is therapy for that. And I'm not sure if Meshan wants me to talk about that now, or we're going to do that later.
I think it'll lead us to some of our other questions a little later. But thank you for expounding on those other symptoms from postmenopause. I think that's also an important transition phase to think of. But speaking of those symptoms, namely hot flashes, I think those are probably one of the most common ones, including night sweats, alongside with night sweats. But could you share what hot flashes are, what causes them, if any, things that, you eat or consume, like caffeine, possibly alcohol, if any of those could be possible triggers, and also how to treat them?
Mm-hmm. So hot flashes, I would say, are usually described as an intense feeling of heat, often in your chest, throat, face, and it might or might not be accompanied like with sweating, right? So you really get wet. Some women get palpitations at the same time. So, you won't really put your head in the fridge, but they might be much milder. And now some women have them a little bit and they're like, doesn't bother me, and some women they are like, well, I always was cold and now just suddenly I have more warm hands and feet and I actually rather enjoy that. That can also happen. But when they're really bothersome, you have this flushing heat that goes to your face. You might be sweating so much for that moment that, the water drips in your eyes. That can be very bothersome for women who have, very demanding jobs, who sit in Zoom conferences, right? And suddenly that really affects their self-confidence and their self-image. So that's the typical hot flash. However, it might also just be you feel a little hotter and you just take a little fan and you're fine. What causes them? Well, that's a good question. I think no one really knows for sure yet, but it's thought it has to do with the decreasing estrogen levels. It does affect the center of thermoregulation in our hypothalamus. And that basically when before the range of what the hypothalamus felt was normal temperature was like this, suddenly it's like that. And so the moment it gets a little hotter or colder, or you get emotional or do some more activity, you are out of that normal range. And the hypothalamus says, okay, let's start sweating. So that's what's, the current understanding of it. In terms of what can trigger it, yes, the usual recommendation is avoid potential triggers, which might be caffeine, it might be exercise, spicy food. That's always written. To be honest, I'm not sure how much that is. It might be attributing that moment, but I don't feel someone eats all the time spicy food and that's why they have a hot flash and we stop the spicy food and it stops. I don't think that's how it works.
All right. I think you answered one of my other questions about exercise and just that intense activity that, it already causes you to sweat in the first place. And then when a hot flash comes, it could, further intensify things. So just being, I guess, more aware of, your body's habits. If you're used to certain foods, used to certain activities, then possibly it may or may not, cause an intense reaction.
Exactly. But, I don't like simple answers. So yes. So, however, there is one more thing I wanted, since you mentioned the exercise before that topic goes away. Exercise as we get older and in perimenopause, often women start to really over-exercise actually because they have more time or they suddenly get a little belly or, then they start to suddenly do these intense gym memberships and work out every day or every second day for 1 to 2 hours. That is going to make things worse. And that really has to do with our I want to make it simple, our energy levels and our cortisol levels. So if you stress your body, and just to use this very broad term, you stress your body with physical activity. There also can be mental stress, of course, but too much exercise is a physical stress actually that raises your cortisol level that can actually also prompt hot flashes. And it can make that problem with that belly weight even worse, because once you have an elevated stress level and elevated cortisol levels, your belly is not going to go away. So very important for perimenopause, I want women to cut themselves a little slack. So exercise and movement is important, really, every day, half an hour, but it can be walking. If you have always been running, well, that's great, but don't run every day for an hour. Really do this once or twice a week and make sure you do more gentler exercise like yoga or Pilates. There are so many, video platforms out there these days. You have to take it really easy. So, and that way you also avoid your hot flashes, right? Of course, if you're lifting weight for 2 hours, you might get a hot flash for many reasons. So don't do that.
Thank you very much. And I think it addresses a few of the audience questions that we've had. So thank you guys for sharing your experience with us, sharing your questions with us. And thank you, Dr. Hensman, for explaining the ins and outs of those hot flashes. Real briefly, could we address the mood changes that women can go through, and does it have anything to do with hormones?
Oh, yes. That's one of my favorites. And I'm going to try to make it simple, but I can't promise. So yes, the hormone changes have to do with the mood changes have to do with the changing hormone levels. And what is really behind it? It has to do with our neurotransmitters. So, neurotransmitters are, for example, norepinephrine or adrenaline or dopamine, you might have heard, or serotonin. So depending how high these levels are, if they're high when we are stressed, or in the past times when the tiger was coming, they would kind of rise. And then our body, however, should be really very quickly metabolizing them, basically throwing them back out the higher levels so the body can relax and recover again. So what's happening now with our lifestyle, but also the estrogen, they interfere tremendously with that. Estrogen does actually slow down the breakdown of these neurotransmitters, and progesterone does the opposite. So what can now happen, for example, is that when people who had, now I want to take serotonin, because some people might have heard that serotonin is kind of the feel-good hormone, and there are some antidepressants actually out there that work by increasing the serotonin levels. So if the serotonin has a good level, we feel good and we can sleep, because melatonin, the sleep hormone, is actually made out of serotonin. So now you can understand, if the serotonin is low, you're also not going to sleep that well. So estrogen helps to keep that serotonin level up. So now imagine in perimenopause, the hormones go on a roller coaster. So you might feel good one moment, and the next moment you want to cry, you're anxious, and you're craving sweets and chocolate, because that is a fast fix to get that serotonin level back up. So it's just one way to explain how our estrogen levels do affect that. On the other way, if the other, like dopamine or norepinephrine, is very high, right, then you can't sleep at night, because you are just so under stress all the time. And again, the varying doses of estrogen will affect that. However, it's important to know these correlations are very complex. And so the reason one woman cannot sleep is not the reason that the other woman cannot sleep. It might have to do with estrogen, but it really depends how the estrogen in that woman is affecting her pre-existing way to metabolize these neurotransmitters. Did I answer your question, Wallace? I tried to make it easy.
Oh yes. I think you did. I think that is a good segue to my next question. Speaking of hormones and hormonal changes and those effects, could you share what hormone replacement therapy is, and what are the current guidelines, and how long on average does a patient stay on hormone replacement?
Yes, very good. Thank you for that. Yes, so hormone replacement therapy. So that is really still considered, so it's the most effective therapy for menopausal hot flashes, for the vasomotor symptoms. And hormone replacement therapy means that during the time when a woman is most symptomatic, we can give we can replace the physiological hormone levels to make you feel better and help with your symptoms, which are the hot flashes, and it's also approved for bone loss, for postmenopausal bone loss. These are the FDA approved indications, the vasomotor symptoms and the postmenopausal bone loss. But we do know it can also help with sleep quality. It helps with mood symptoms and the brain fog. How do we give hormone replacement therapy? So there are usually there are two hormones involved, the estrogen and the progesterone. Progesterone is that hormone that's usually released after we have released an egg, and that is then thinning the endometrial lining and preparing it for menstruation. So now there are two scenarios. There are women who already had a hysterectomy. These women don't need the progesterone because they have no endometrium. They can only go with estrogen therapy, which has a slightly better risk-benefit profile, actually. And then women who have a uterus, they would take estrogen and progesterone. So here I want now to reach out a little bit. I know many of you have heard about bioidentical hormone replacement therapy, and it's marketed a lot like it's a better option, and then it's offered compounded, like made for you. So, and it always make it seem like what we in conventional medicine or big pharma is offering is like not that good of an option. So here I need to clarify what your doctor can prescribe you is most of them are actually bioidentical, particularly if you ask for it. So most estrogens out there prescribed these days is estradiol, which means it's made in a lab, but it looks exactly like that hormone that you would produce. And that's an opposite to what was used in the early years of hormone replacement therapy. There we had mostly the Premarin or conjugated estrogen, which was made from horse urine. So that's where many people think that we are still giving this in big amounts. We usually don't. I've never prescribed it, for example. It only comes as a tablet. So the bioidentical estradiol is available as prescription, as a patch or a gel or a spray. And the progesterone, that is the bioidentical progesterone, can also be prescribed. It's usually as a capsule because the really bioidentical progesterone is not well absorbed transdermally. So that has to be given as a tablet or a capsule in order to reach your endometrium and prevent an abnormal proliferation of that. So that hormones are available as a tablet, as we call it oral therapy. I think most advanced menopausal practitioners these days, we like to prescribe it as a transdermal preparation. And the reason is that it does not have to pass the liver that way. That means whatever you take in your mouth has to be chumped up by the liver first. And then it depends how your liver breaks this down, how much you will get. That's one reason. And the other reason is whatever has to go through the liver affects your blood clotting factors. And now comes that leads us over the risk of hormone replacement therapy. It's actually blood clots. The overall risk is really very low. But if you have risk factors like uncontrolled hypertension or you had a stroke, that is a contraindication to hormone replacement therapy. The current statement of the North American Menopause Society is that in young menopausal women, meaning less than age 50 and recent onset of menopause, for most women, the benefit outweighs actually risks. And that is an opposite to women once they are older than 60. That risk-benefit equation does turn around. And for these, when they did not start on hormone therapy in the 50s, and now they're 10 years already in menopause, and then they would say at age 65, now I would like to start it. Here now the risk outweighs the benefit. So these women will have an increased risk of blood clots, stroke, cardiovascular disease, and gallbladder disease. There's always discussed in the media the risk of breast cancer. Here's to be said that that data comes from the World Health Initiative study, a very big study started in the late 1990s and then early stopped because they thought they had an excess risk of breast cancer and cardiovascular events. In the end, it turned actually out that the excess risk of breast cancer was only seen in the women who needed to take the progesterone or progestin. So that's now important. Back then, the only progesterone was a progestin, which is a synthetic progesterone. It's not the real thing. And only the women who had to take that because they had a uterus, they actually had the increased risk of breast cancer after 3 to 5 years. We do think there's no great data, but there's some data that really seems to show that if you give first, estrogen transdermally, there's a much lower risk of cardiovascular events and blood clots. And for the progesterone, we experts actually do think that the bioidentical progesterone does not have the same risks than the synthetic progestins, but that hasn't been 100% proven. But so yes, that I personally do stay away from the progestins. But even if you have to take these, there's no increased risk, or after 3 to 5 years, that risk only goes up. And it translates in about 3 cases of additional breast cancer per 1,000 women year. I know this might be just a number for you guys, but that is really a very low risk. And for the women who only had to take estrogen, there was no increased risk of breast cancer after 7 years. Did I kind of, so I'm stopping in now. You tell me what I missed.
Yeah, I think you covered it all. I think we had a few questions regarding hormone replacement therapy, including from Devette and how it can impact cancers in women. A few other viewers have also addressed it. So it seems to be a pretty common treatment option that's probably recommended. How long though? How long can someone expect to stay on that type of treatment?
You know, there is no strict cutoff. I usually, you know, let's say the woman is 52. You know, I would say most women after 3 to 5 years, they like to wean down, or, you know, sometimes they stop at cold turkey and then they don't feel good. And I say, well, why are you doing this? They are very varying doses that gradually decrease. We can slow it down. Right. And it depends on the personal risk profile of the patient. So, you know, if every couple of years, you should reassess where a patient is. Has she become hypertensive now? Has she had a heart attack? Is there anything going on with her breast tissue? But if that woman remains low risk, there is no strict cutoff anymore, actually. So I know I've said before that over age 60, but that was in reference to if you have a new start of hormone replacement therapy at age 60, we don't recommend that. For women who have been on hormone replacement therapy early on, it's a very gray area if they have the same increase in risk after age 60. So then, you know, at age 60, I would always, you know, recommend a woman to start slowing it down and we decrease the dose. But if they don't want, or we try and she becomes so symptomatic again that she cannot function, it's always a discussion. You know, I explain it to you, we discuss, and the patient can make the decision she would like to stay on it. So the North American Menopause Society does not mandate any particular age that you have to stop it. I often get patients referred where the primary care physician just says, no, that's it, I'm not giving it to you anymore. That is actually not up to date anymore.
All right, thank you very much. It's good to know that, you know, with the help of menopause specialists like yourself and others on our team, that there is a tailored plan for treatment, depending, you know, on what stage of life you're going through, how old you are. So it's good to know that there is that possibility for personalized care. So thank you very much, Dr. Ensman. We're going to wrap it up, but I see we have a lot of activity in the chat on Facebook. Thank you guys so much for tuning in and sharing your questions with us. We will take some time to answer those offline as well, but we'll make sure to address your questions. But I just want to wrap it up for a bit. What can a woman do about the recurrent urinary tract infections?
Yes, so so if it's due to genitourinary syndrome of menopause, meaning the vaginal tissues is already very dry, there's discomfort with intercourse, and there's recurrent urinary tract infection or urinary frequency. So very effective treatment is actually vaginal estrogen therapy. This is now different from the systemic hormone replacement therapy we just discussed. So the estrogen I give in the vagina is actually barely absorbed, if at all, in the body. It really just helps locally that tissue. And that's why you actually can stay on that until the rest of your life. There is no contraindication against it unless you had hormone sensitive breast cancer, then this needs to be discussed with the oncologist. But yeah, so the vaginal estrogen that is given as a suppository or a cream is highly effective for pain with intercourse or the recurrent urinary tract infections. I see that often these women get that prescribed from some practitioner, but they don't get enough. So they come and they say it doesn't help. So I feel in my practice, you often have to give this every night for 3 weeks and then space it out to 3 times a week. I always say I up estrogenize that vaginal tissue. So that is something that can be done and is very effective, and you shouldn't be afraid of it. The other options, let's say the woman is still in perimenopause, or actually the estrogen is still kind of there, but she has these recurrent urinary tract infections. What I really like is a supplement, and it's called D-Manose. It's a supplement that you can get over the counter, and it has been used in functional medicine for a long time to prevent recurrent urinary tract infections. And about 2 years ago, there was actually a randomized controlled trial that actually has shown that that is superior to a daily antibiotic treatment. So that's one of my favorites.
Thank you very much for sharing that. We also had an audience question from Laura related to that preventing vaginal dryness. And any risks related to that. One quick note: is it related to the cream for vaginal dryness? Is it okay to use, or are there any like cancer risks? She's mentioning endometrial cancer. Could you
No, not at all. So the very low doses of vaginal estrogen are so low that you actually do not need to take a progesterone or progestin to protect the lining. It's not needed, okay? So no, you don't. And there are and otherwise cancers, as I mentioned before. So if you had an estrogen positive breast cancer, your oncologist might object to it. Even the official statement of the North American Menopause Society is that if your symptoms are so affecting your quality of life and cannot be controlled with other measures like regular lubricants, etc., it still can be a consideration.
All right, thank you very much, Dr. Ensman, and thank you, Laura, for sharing your question with us. I'd like to wrap it up with this question for you, Dr. Ensman. So in your experience with patients, how do you think women feel overall about menopause, and what can be done for those who are either dreading this phase, like I'm not in this phase just yet, I'm pregnant with my first baby, I'm hoping it's a long ways away for me, or for those people who are just currently in the thick of it and have a lot of anguish about a lot of stress and don't know how to deal with it. What encouragement or final words do you have for those? Yeah,
I love to quote one study that actually showed that most women in menopause, like 70% of women, state that they are happier than they were in their 30s. So I'm always like, see, people, that's all fine. So yes. And then I would say most women are just, in general, there's just no good education about menopause and what to expect. So I appreciate a platform like this to give women just to think about it, to hear about it, and then just to know, okay, it's not so bad. There are just a couple of things I have to consider. I think it's always a good time to check in with your doctor, and hopefully you have a good physician who can give you a little plan, to give you some oversight what's going to happen. And but it should be menopause or the time of change. Most women, it seems to me, really go very easily through it if they have reached a point in their life where they can control their stress, they eat healthy, they try to move. These are women, they often just miss entirely the menopause. They come back, they are 55, and they said, oh yeah, that was a couple of years ago, not a big deal. So I wouldn't worry at all, but make sure you get the information you need and be prepared, and start in your 40s with, the lifestyle changes. Don't wait until it hits you. It's amazing what you can do with nutritional intervention and a little bit of movement and thinking about your outlook in life and what you like to do.
I really like that. Thank you. Thank you so much for providing that encouragement. That makes me feel better about entering this phase when it eventually comes. So thank you very much, Dr. Ensman. That's all the time we have for today. Thanks, Dr. Ensman, again for joining us and sharing your expertise with us and giving us those tools and resources that we can use as we manage menopause. And thanks so much to everyone who tuned in, shared your questions, shared your experiences with us. We really appreciate you doing that. If you're interested in learning more, or if you'd like to request an appointment with the women's health specialist at MedStar Good Samaritan Hospital, please call 443-444-5711 or visit medstarhealth.org/Ensman. That's Dr. Ensman's last name, Enzmann. We're going to add that information in the comments for you as well. And for other menopause resources, please visit redhotmamas.org. We'll provide all that information for you again in the comments. So thanks again for tuning in, and everyone have a great day.
Thank you, Mashan. Bye-bye.